Have you suppressed them all? Anyway, thank you very much. Thanks.
Of affordable anti-VEGF drugs. The background is diabetes mellitus. A survey of NPCB visual impairment done in 2015-19 showed a prevalence of diabetic retinopathy, repeated injections of intravitreal anti-VEGF injections, which are unaffordable to most of our country's population. So our aim and objective was to develop a replicable and sustainable eye care delivery model to ensure affordable, timely, and accessible care to all diabetic retinopathy patients in Thrissur district, to involve both public and private institutions providing retinal care and supervised by the district ophthalmic club. So the first phase in 2019-20, the Thrissur DOC started a community outreach program called the Taco Deepam. And the main project of this initiative was the Diabetic Retinopathy Evaluation and Management Mission, or the DREAM mission. The first phase conducted diabetes detection camps. We did educational programs. We conducted physician organizations in the district to refer diabetic patients. And the final evaluation was done in the DREAM clinic by both the community medicines and the DOC members from both private and government institutions. And the observations which we found was that there was poor eye health seeking behavior among diabetes patients, low knowledge about diabetic retinopathy causing blindness, poor access to trained retinal specialists, and inability to afford anti-VEGF injections. So the DREAM phase 2 was started, where we developed an eye care model. The DOC held a series of meetings with institutions which provide retinal care, and various models were discussed and finances were discussed. And this led to the development of a public-private cooperative model based on the concept that one multi-dose injection of Avastin can be subsidized for 10% of patients in 1 month. So we developed a Taco Deepam website, and 6 private ophthalmic hospitals registered their services here. And the key components of the model was that the initial screening was done by the ophthalmologist at the first point of contact. If the need was an intravitreal injection was felt, a free macular OCT was done from the Government Medical College, and then the patient registers at the website page. He can choose the hospital, upload the report, and which goes via email to the institution. The institution will contact the patient, fix a free OP appointment, and subsequent delivery of subsidized anti-VEGF injection at mutually convenient dates. The DOC, or the District Ophthalmic Club, is not to be held responsible for any lapse of service, which is the sole responsibility of the hospital providing the injection. And through the portal, patient can access educational material and other social services. He can interact with office bearers. So the results of this phase 2 was July 2021 to 23, 512 registrations from 423 patients were received. 63% were males, and the ages ranged from 26 to 82 years with median age of 62 years. Though there were many indications, 86% of patients were referred from government institution, and diabetic retinopathy was responsible for about half the referrals. The accessibility issues, the website encountered access issues during 2 periods. The first one was in July, where there was a re-registration of the website, and in December, where a change was required in the calendar settings. However, patients were able to contact the DOC admin through the email option. The advantages of the model: it used friendly software. The registration form could be accessed on mobile. Daily registrations were received by admin through mail, and it was highly cost effective and less slow maintenance. The advantages of the service delivery: patients received appointment within a week and given standard but subsidized care. Easy scheduling of subsequent follow-up was done, and issues could be easily sorted out. All participating institutions saw an increase of patients in their retina practice. But some of the disadvantages: that elderly patients required help for registrations, smartphone was needed for access, and technical support was needed for maintenance of sight. And so the present model built by the DOC fulfills all the criteria of an effective community intervention model. It addresses community needs, understands its constraints, provides easily accessible, affordable, and evidence-based care, generates health-seeking behavior, gives a digital report for the entire district, and advantages to all participating institutions. And the DOC supervision as an organization is best suited for coordinating and monitoring the activities. It provides an insider's understanding of the community. It can tackle implementation difficulties. Finances and costs are open to scrutiny, and other social networks or activities of the DOC get publicity. So the same kind of a discussion was done by Bhusnoor Math, who discussed a hospital-based community eye health program as a sustainable model without creating permanent posts. All recurring expenses like consumables, spectacles were absorbed by the hospital as part of their regular annual budgets. Our Taco Deepam model too is hospital-based, ensures subsidized and coordinated clinical care with minimal costs and no liabilities to the DOC. Thus, our project is also sustainable. District clubs can therefore play a pivotal role in providing a common platform for collaboration in public health initiatives. Effective community ophthalmology services can be provided by a spirit of cooperation, inclusion of both public and private comprehensive eye care providers with freedom of choice regarding the provider and schedule ensures active participation of the individual, and all institutions participating receive recognition and goodwill, which will provide long-term benefits. These are my references. Thank you.
This website and the sponsor, who is sponsoring the upkeep of this website
The
as well as
DOC.
DOC only?
Yes.
From their own income, they are doing it as
Yes.
a
Yes.
charity
Yes.
activity. Okay.
We have some fund for it.
Approximately, what is the monthly or yearly cost?
The yearly cost actually for this initial cost was 40,000. Then the maintenance was 3,000 every year. For that thing you have to maintain.
How do you advertise that this is happening to the DR patients? You go through hospitals who are taking care of DR or directly
They
patient?
get a call. They can choose the hospital. They get a call, and then when they get the call, they can select the time they want
Okay.
to get the injection, and that time is between the two people, the hospital and the.
So the government is not directly involved in this anyway.
No, government is not acting. The point is that if on a single day you can give injection of Avastin for 10 people, one of it can be subsidized.
Correct.
That is the main thing. So that is the advantage which we found for this model, and it helped them.
Great effort. Nice.
Thank you.
Next, we have Dr. Manju. Manju, correct. She's going to talk about treatment outcomes of vitrectomy, hyalodectomy, zolectomy in malignant glaucoma patients.
No, that not that. $31. Start. Good morning. The topic is the treatment outcomes of plasplana vitrectomy, hyalodectomy, zonelectomy, and iridotomy in malignant glaucoma. Malignant glaucoma is defined as uniformly shallow AC with patent PI, which occurs after many ophthalmic procedures and is considered as a refractory entity. The aim of the study is to study the efficacy and safety of plasplana vitrectomy, hyalodectomy, zonelectomy, and iridotomy in malignant glaucoma in Indian eyes in a tertiary care center. The medical records of the patients were taken between December 2018 and August 2022. Patients who underwent the surgery were included in the study. Demography, diagnosis, best corrected visual acuity, and lens status were recorded. IOP, number of anti-glaucoma medication at presentation and follow-up was recorded. This is a surgical procedure. After the initial anterior vitrectomy, the plasplana vitrectomy is done with a setting of 5,000 cuts per minute and 650 aspiration rate with a vitreous base shaving. And hyalodectomy with a PC cutting is done with 2,500 cuts per minute and 650 aspiration rate. And zonelectomy and iridotomy is done with the similar settings. So anatomical success was defined as deepening of the central anterior chamber. Complete success is defined as intraocular pressure less than 21 without any anti-glaucoma medication. Qualified success is defined as IOP less than 21 with anti-glaucoma medication. Failure is defined as flat anterior chamber or IOP more than 21 with anti-glaucoma medication or patients requiring a second procedure. Coming to the results, 36 eyes of 30 patients were included, 17 were females, 13 were male, mean age of 70 plus or minus 10, 19 underwent cataract surgery, 35 eyes were pseudophakic and 1 was aphakic. Cataract surgery was the most common primary procedure, occurred in 66.7%. Primary procedure of 16 patients were done in our hospital. 14 patients were referred to us for expert opinion. B-scan was done in all the patients to rule out suprachoroidal hemorrhage or CDs. 3 patients had aqueous pockets in B-scan. There was statistically significant improvement in mean visual acuity post-procedure with a p-value of less than 0.001. Duration between the primary procedure and malignant glaucoma was 18.2 days average. Duration between the development of malignant glaucoma and the surgery was 2.61 days on average. 13 patients were operated on the same day. There was statistically significant reduction in the intraocular pressure each post-op visit. Intravenous mannitol was given in 17 patients at the time of presentation and 22 patients 30 minutes before procedure. The reduction of anti-glaucoma medication was statistically significant for all the follow-up visits. Atropine 1% was continued in 1 month post-operatively. At 6 months follow-up visit, 19 patients were not on any anti-glaucoma medication. 3 out of 36 eyes, that is 8.7% of eyes failed. 16 out of 36 eyes, that is 44.4% achieved a complete success. 47.22% achieved qualified success, and a total success of 91.6% was achieved. This is a Kaplan-Meier analysis curve of complete success and the qualified success. Coming to the discussion. The principle of surgical management of malignant glaucoma is to re-establish a communication between the anterior chamber and the posterior chamber. Mean age was 70 plus or minus 10, and similar study by Raj et al. Studied a younger participant, that is 66.4%, 4 years. 56.33% were females. Debroni et al. In their study stated that malignant glaucoma is more common in women because of the location of the lens is more forward. The principle of the surgery is adequate removal of the core vitreous that can reduce the recurrence rate compared to other surgeries. Mean IOP at presentation was 37.9 and mean for IOP at follow-up was 13.79. Raj et al. In their study, IOP at presentation was 26.25 and final follow-up was 15.9. Zarnowski et al. Pre-op IOP was 37.7. It was reduced to 13.5. So reduction in IOP in this study was comparable to previous studies. The mean number of anti-glaucoma medication at presentation was 2.64 and at final follow-up was 0.38. Similarly, Raj et al. Mean number of anti-glaucoma medication at presentation was 1.95, final follow-up was 1.45. And Balakundru et al. The mean number of anti-glaucoma medication at presentation was 2.1 at the onset and final follow-up was 1 plus or minus 1.6. There is more reduction in anti-glaucoma medication compared to previous studies in the current study. 97.22% achieved anatomical success and 91.6% achieved total success, and none of the patient had relapse. Raj et al. In their study said 87.2% as successful outcome. Dobrone et al. Studied anterior vitrectomy, iridectomy, zonelectomy. Initially, they had a final favorable outcome, but 66% of patients relapse. So the total vitrectomy with vitreous-based shaving in this study, the surgery prevents the secondary blockage of the tunnel that is created, preventing the recurrences. So in this, there are many studies which studied more number of eyes, but they studied different surgeries. So this is one of the studies with largest number of eyes, which solely analyzed this surgery, and previous studies had more recurrence and this study didn't have any recurrence. So malignant, this is the example. Malignant glaucoma is an 83-year-old patient with underwent phacotrabeculectomy. Day 4 is the pre-op presentation with a shallow AC and IOP was 63. And this is a post-op picture 2 weeks with a deep AC with you can see the surgical PI. IOP is within normal limit and the patient is not on any anti-glaucoma medication. This is a bilateral malignant glaucoma. This is a post-op picture. The patient underwent surgery in the both eyes. Post SICS, patient developed malignant glaucoma. And post-procedure right eye AC is deep. Patient IOP is 14 and not on single AGM. Left eye IC is deep. IOP is 18, not on any anti-glaucoma medication. This is also a post-op picture of the patient, and AC is deep, IOP is 16, and not on any anti-glaucoma medication. What was known before the surgery is that malignant glaucoma is a refractory entity, and there are many surgical and medical treatment. Among various surgical options, newer modalities can have a better outcome. Recurrence rate of malignant glaucoma is reduced by continuing cycloplegics. This study adds is that it has a larger sample size compared to previous studies. Exclusively assess this plasma vitrectomy, hyalotomy, and zonelectomy surgeries, and the success rate is reported as 91.6, anatomical success of 97.22% achieved. None of the patients had recurrence because as there is a reversal of the aqueous mistillation due to tunnel effect and the total vitrectomy with vitreous-based shaving preventing the secondary blockage of the tunnel. So in conclude, even though malignant glaucoma is considered as a refractory entity, the plasma vitrectomy, hyalotomy, zonelectomy, and iridotomy surgery can achieve favorable outcome with reduced chances of recurrence. Thank you. Yes. No, all the patients had laser, PA, and surgical. No, no, sir. Don't know, sir. I don't know.
Three cases failed. No?
Yes, sir.
How were they managed?
Failed cases.
Failed cases.
Diode CPACs, sir.
Diodes.
One
Meaning,
case was
failure means the control of IOP was not controlled, or the AC did not form.
No, AC not formed in only one case, sir.
Okay.
That AC reformation was done in that case. But other cases, one case has no PLI, other one underwent diode CPAC. So any patient.
In spite of AC reformation, the pressure did not come up. Huh? What do you mean by that? What do you mean by failure? That's what I want to ask.
Sir, there is failure mainly means IOP is more than 21 even after even after AGM.
Okay, okay. So not the deepening of the AC was not the parameter.
That was anatomical success.
Okay,
we
that
have
was
taken.
okay.
That was achieved in 97%. Only
Okay,
one patient didn't have ACL. That patient underwent ACL reformation.
okay,
So that's one more.
okay. Second organ next talk is okay. Micropulse CPC.
Yes.
Okay,
Good morning. The topic is safety and efficacy of micropulse transcleral psychophotocoagulation in eyes with refractory glaucoma. So, refractory glaucoma is defined as uncontrolled glaucoma despite previous filtration surgery, laser treatment, or under maximum medical therapy. Micropulse transcleral psychophotocoagulation delivers focal delivery of energy to the non-pigmented epithelium. Delivers 810 nanometer of energy with duty cycle of 31.3%. Allows tissues to cool in between the pulses. It claims to have equal efficacy and better safety compared to diode CPC. The need for this research are there is few studies that describe the real life experience of efficacy and safety of cyclogesics in Indian population. So, to evaluate the safety and efficacy of micropulse transcleral cyclophotocoagulation in eyes with refractory glaucoma, and we are describing our real life experience. So, coming to the methodology, retrospective case series data is taken from the electronic medical record. 36 eyes of 36 patients with refractory glaucoma who underwent cyclogesis is taken. Pre-op and post-op data on biscular visual acuity, IOP, and anti-glaucoma medication were taken. Post-op follow-up of day 1, month 3, month 6, and 12 were taken. Primary outcome was defined as reduction in intraocular pressure. Secondary outcomes were reduction of anti-glaucoma medication and the number of complications. And success is taken as 20% reduction of IOP from baseline. Statistical analysis was done by SPSS version 16. The setting 2000 milliwatt, 80 seconds, 180 degrees was treated with 80 seconds. Viscoelastic is applied. Probe is kept at the limbus and moved 180 degree over 20 seconds. So this is the procedure. The viscoelastic is applied. And the probe is kept. And the probe is steadily moved. So 180 degrees treated in 20 seconds, and it is moved back and repeated once again. So 180 degrees treated in 80 seconds. So we use IDEX Cyclogesics P3 Pro. 20 seconds per hemisphere sweep and 80 degree total per hemisphere. Both hemisphere 160 seconds. Coming to the results, 36 eyes of 36 patients were taken. 66.67% were males. Mean age was 50 plus or minus 19. 66.67% were right eye. Secondary glaucoma was seen in 63.8% and 72.22% didn't undergo any previous surgeries. Mean visual acuity changed from baseline value of 5/60 to 6/60 in 12 months. Mean IOP reduced from 37.7 plus or minus 12.9 to 21.1 plus or minus 8.2 millimeter mercury in 12 months, and it was statistically significant. Mean anti-glaucoma medication reduced from baseline of 4 to 3 over 12 months. Success was defined as 20% reduction from baseline IOP, and a total success of 66.67% was achieved, and there were no major complications. Coming to the discussion, 36 patients were enrolled in the study. Mean age was 50 plus or minus 19 years, and predominantly were males. Similar study by Kuchar et al. Included 19 patients. Mean age was 71.9 years, and the patients were predominantly females. We included a younger population in the study. There was significant reduction of IOP measurement over 12 months. Similar study by Giancarlo et al. Did a retrospective analysis of 116 eyes of 116 patients, and IOP was reduced from 22.79 millimeter of mercury to 15.3 millimeter of mercury. We had a higher baseline IOP compared to other studies. Total success of 66.67% was achieved in 12 months. Tan et al. In 2010 analyzed the efficacy and safety of micropulse transcleral diode CPC in 40 eyes with refractory glaucoma and reported a success rate of 80% with a follow-up of 16 months. Our success was almost comparable to previous studies. It's a case example, case of uveitic glaucoma, which was refractory on 4 anti-glaucoma medication, and patient had bremonium and analgesic. On top of that, she developed a reticular edema to netazoidal eye drops. So cyclogenesis was done, and IOP is controlled with 2 anti-glaucoma medications. So it is useful in patients with drug allergies. And this patient, 46-year-old patient, case of secondary glaucoma due to eye syndrome. Patient was having refractory glaucoma, was on 4 anti-glaucoma medication. Cyclogenesis was done, and IOP is under control on 3 anti-glaucoma medication, and the patient underwent NPDS. So it was useful in patients who needs short-term reduction of IOP and to plan a definitive procedure. And it is a one-eyed patient, 12 years old, case of aphakic glaucoma, both eyes, which was refractory, and patient was on 3 anti-glaucoma medication in right eye, and IOP was high. Cyclogenesis was done, and IOP is now under control on 2 anti-glaucoma medication. It's useful in one-eyed patient and especially children due to its good safety profile. 15-year-old patient with secondary glaucoma post PKP, left eye is refractory, and patient was on 4 anti-glaucoma medication. The best corrected visual acuity of the patient was 6/60. Cyclogenesis was done, and IOP is under control on 3 anti-glaucoma medication. BCVA is 6/60. So visual acuity is maintained and is better for patients with good visual acuity. And it's also a 10-year-old boy, a case of traumatic glaucoma, right eye refractory on 5 anti-glaucoma medication. Cyclogenesis is done, and now IOP is controlled on 2 anti-glaucoma medication. And this is the point where the cyclogenesis was done, and there is a steep reduction in IOP. So to conclude, MicroPulse transcleral cyclophotocoagulation is a safe and effective method of lowering IOP in cases of refractory glaucoma. Thank you.
So it's helpful for short-term control, no? So what's the duration of efficacy?
That control, mainly 3 years maximum.
Maximum 3.
And we can repeat it. That's one.
Topical or block?
The block only, sir. We usually do under. Mainly, actually, one thing is that some of the cases were children, and then also we block and. Like if there is any pain and no, we do. Thank you, sir.
Not this. Dr. Nadina.
So next we have Dr. Anaswara John. Yeah,
Nadina.
which next page? Yeah. Leaving it. Dr. Nadina Bashir on outcomes of femto-assisted cares and simultaneous corneal collagen cross-linking. Okay, keratoconus.
Good afternoon, all. My study is on outcomes of femto-assisted cares and simultaneous corneal collagen cross-linking in keratoconus. Keratoconus is a bilateral, asymmetric, non-inflammatory progressive thinning of ectatic corneal disorder. Often due to the high irregular astigmatism, spectacles and contact lens corrections are dissatisfactory. Usually collagen cross-linking is used for stabilizing the disease process. The purpose of our study is to evaluate the visual and topographical changes occurring following femto-second assisted corneal collagen, corneal allergenic intrastromal rings care split with simultaneous cross-linking. It is a retrospective case series on patients diagnosed with keratoconus and underwent femto-assisted cares. The study period is from September 2018 to March 2023. The inclusion criteria included patients diagnosed with keratoconus above the age of 18 years and with a best corrected visual acuity of 6/9 and below, and cylinder power of more than 2.5 diopters and pachymetry more than 400 microns. The exclusion criteria included central corneal scarring and visual acuity less than 1.2/60, not improving with the glasses. So the procedure is explained with a video. First, First, the stromal pocket is produced by the femtosecond laser. Then the donor cornea is removed of the epithelium and endothelium is stripped off. Using two different sizes of corneal punch, femtosecond KS segment is created and it is fashioned according to the arc length required. Trimming of the edges is done and it is inserted into the stromal pocket, which is already created using a pigtail stromal dissector. This video shows a double KS segment, asymmetric double KS segment. After this, epithelial debridement is done and cross-linking is done in the same setting. 22 eyes of 20 patients with keratoconus were included in the study. The mean age group was 25.9, plus or minus 7.8. 10 eyes were females and 12 were males. Mean follow-up period was for 10 months. The visual changes measured were the uncorrected visual acuity, which improved from 1.06 plus or minus 0.2 to 0.75 plus or minus 0.2, and best corrected visual acuity improved from 0.9 plus or minus 0.2 to 0.3 plus or minus 0.5. Sphere, the spherical mean sphere improvement from 3.2 plus or minus 4.8 to 0.5 plus or minus 1.23. Refractive cylinder power is also increased from, improved from 4.35 to 2.4. This mean spherical equivalent showed improvement from 5.15 to 1.79, and all the p-values were statistically significant. Then coming to the topographical changes, we measured K1, K2 and Kmax. It showed improvement in all and p-value was shown statistically significant. The only complications we have found was mild stromal inflammation in 5 eyes, which was well controlled with a topical steroid application. This is a patient which came to us with preoperative vision of 660, which was improving with minus 6 cylinder, improving to 618. This is the topography where you can see the steep point is around 58.2. After case, the 1 month after case, the postoperative vision acuity improved to 624. With minus 1.5 D cylinder, it improved to 612. So you can see the steep area is well flattened. That is around 58. It reduced to 47. You can see the flattening here. Around 11 diopters, it has flattened. This is the clinical photograph of the KS segment, and this is the ASOCT, where you can see the implant is placed 230 microns from of depth, and the total thickness of the KS used was around 580. This is another patient who came with asymmetric bow tie with inferior steepening. So this is pre-op. The visual acuity was 5/60, improving to 618 with 3.5 diopter cylinder. Here the mean, the steep point is around 59.3. This is post-operative, where you can see it's well flattened and the steep point is around 45.4. The visual acuity improved from 5/60 to 636, improving to 69 with 3 diopter cylinder. So this is the clinical photograph of the same patient, and you can see the ASOCT segment image where the KS is implanted at 200 microns depth. So coming to the discussion, cross-linking is used for stabilization of progressive keratoconus. In a study conducted by Hendricks et al., they found that overall progression is around 2.2, which is very good, and progressive extreme flattening is occurring in some of the cases. That is around 7 patients develop progressive flattening, which has caused a loss of best corrected visual acuity. Among that, one eye had a flattening of around 11 diopters, which needed a corneal transplantation. Now, the complications of cross-linkings are very minimal, but the most common is the postoperative stromal haze and the progressive flattening, and rarely now we are finding corneal melts and thinning associated with this procedure. So in this setting, it is better to give an additional additive procedure like an intact or a KS to support the host cornea. KS have better biointegration and lesser complication rates like extrusion, migration, neovascularization. Similar study done by Jacob et al., where they included 24 eyes of keratoconus, KS with cross-linking. So there they have found that stromal depth is around 314. Their average improvement was 2.79 lines in uncorrected and 1.29 lines in the best corrected visual acuity. Study conducted by Jafari Nasab et al. And Hadi et al., they also found that the refractive error was getting improved with the stromal implants. Here, in the study, they didn't combine cross-linking together. The two additional points which they told is that displacement of the C point towards the corneal center, which improved the visual quality, as well as the improvement in the third and fourth order aberration due to reduction in myopia. Limitation of our study was that we didn't include the higher order aberration. So conclude, KS with CXL is a newer modality of treatment for improving the visual quality as well as topography of patients with keratoconus. They can either eliminate or delay the need for keratoplasty. Further, long-term studies are required to plan KS as a standalone procedure. These are my references. Thank you.
Sir, it decreases the risk of melt, no? How does it, how do you propose that this helps in preventing melt? Post C3R
without C3R, sir. If KS alone is a standalone procedure, then we can reduce the melt.
Okay. You're trying to say this prevents C3R related melt, no?
Yes, sir.
How does it, what do you propose the mechanism here?
The proposed mechanism is that because of cross-linking, there is damage to the keratocytes that can cause later on thinning. So to prevent that, if the KS alone can be used, we need further studies like that.
Thank you.
Good morning. I am presenting Masquerades in Chronic Conjunctivitis, which is a retrospective review of clinical and histopathology reports. Conjunctivitis is an innocuous condition which is self-limiting, but when lasts for more than 3 weeks, it can be considered chronic. This is the old classification of chronic conjunctivitis as per Krashmer, and I am concentrating on cicatrizing conjunctivitis, which include ocular cicatricial pemphigoid, Stevens-Johnson syndrome, alkali burn, and trachoma. We aim to evaluate for hidden pathologies in cases of non-resolving chronic conjunctivitis. This is a retrospective case study, and we included patients who underwent conjunctival biopsy from January 2020 to August 2023 in a tertiary eye care center, and included a total of 19 cases. So patients who presented with symptoms and signs of chronic conjunctivitis, which were progressing even with medications, were subjected to conjunctival biopsy, which included taking 2 samples, approximately 0.5 to 1 mm in size, from the conjunctiva where the disease is active, preferably the inferior bulbar conjunctiva, and subjected to histopathology and immunohistochemistry. Coming to the results, most of the patients were females, and most of our patients belong to the age group of 40 to 60. 4 of our patients had contributing factors. 2 of them were known case of Bishop's on immunosuppressants, and 2 patients were on AGM for a long time, raising the suspicion of AGM-induced OCP. And analyzing the histopathology reports, we had 1 patient who came positive for immunofluorescence for OCP, 9 came negative for immunofluorescence for OCP, 7 patients came positive for lichen planus, 1 patient came positive for SIN. This patient was later subjected to incision biopsy of the lid and came positive for meibomian gland carcinoma, and 1 patient had features of chronic inflammation. Coming to the management, most of the patients with OCP, symptoms were controlled with topical immunosuppressants, whereas lichen planus patients required systemic immunosuppressants for improvement of symptoms. And the patient who presented with chronic inflammation was better with topical immunosuppressants. So, in addition to this old classification of cicatrizing conjunctivitis, we are now adding conjunctival lichen planus and ocular surface neoplasia. OCP is a chronic relapsing remitting bilateral conjunctivitis. It affects primarily conjunctiva and the mucosa, and it is a diagnosis of exclusion. When there is no history suggestive of Steven Johnson or chemical injury or trachoma, we can reach to OCP. It's an autoimmune type 2 hypersensitivity reaction. Association with HLA-DR4 and DQ7 is said, and common age group is 60 to 80, rarely younger than 30, and most commonly affects women. This is the staging of OCP. Stage 1 is subconjunctival scarring and fibrosis. Then it progresses to pharyngeal shortening. Stage 3 is when there is formation of symblophron. And finally, ankyloid blephron formation with keratinization of ocular surface and limbal stem cell deficiency. Direct immunofluorescence is the gold standard. We can see linear deposition of IgG, A, M, and complement 3 proteins along epithelial basement membrane zone. But the sensitivity is only 50%. So even if immunofluorescence is negative, we cannot exclude OCP. Hemtoxylin and eosin will show inflammatory cell stain pattern. There will be a decrease in goblet cells and increase in mast cell population and pass positivity. Coming to the management, for mild staging of disease, preservative-free lubricants can be helpful in controlling the dry eye, scleral lens for controlling the irritation of the ocular surface, and topical cyclosporin and tacrolimus. But in moderate to severe disease, it will require dapsone, which is a drug of choice as per literature, or oral corticosteroids with immunosuppressants, and the most severe stage of the disease will require cyclophosphamide. Comparing with other studies, Christina et al. Study said they required only artificial tears for control of symptoms in 2 patients and oral steroids for 1 patient. Mukherjee et al. Study said that they required oral steroids and oral immunosuppressants for better control of symptoms. Conjunctival lichen planus, isolated ocular LP is rare, and it's an inflammatory autoimmune condition with unknown etiology. It involves eyelids, conjunctiva, and cornea. It is clinically indistinguishable from other causes of cicatrizing conjunctivitis, and biopsy shows irregular coarse band of fibrin deposition over the basement membrane. In the management, topical steroids, systemic steroids, cyclosporin, retinoids, and cyclophosphamide, depending upon the severity of the disease. Pakravan et al. Study said that they required topical steroids and immunosuppressants for control of symptoms in their patients. And Brewer et al. Study said they required only topical immunosuppressants for control of the symptoms. We had this patient who was on oral azathioprine but showed increased conjunctival adhesion, and oral steroids were added, but still it progressed to sterile corneal ulcer, which resulted in melt and then perforated and self-sealed. Finally, tasography was done and oral immunosuppressants were stepped up. Another patient who was on 2 oral immunosuppressants developed perforated corneal ulcer, which was self-sealed. Oral immunosuppressants were stepped up, but still the patient presented with 2 episodes of recurrent ulcer, which subsided with topical antibiotics and steroids. And the patient is continuing oral immunosuppressants. Sebaceous gland carcinoma masquerades as benign inflammatory disease. It's a rare malignancy, and it comprises less than 1% of all eyelid tumors. Our patient presented with blepharitis keratoconjunctivitis with stage 3 cicatrization. Conjunctival biopsy was done, which showed CIN. Owing to the non-resolving blepharitis and lid margin thickening, incision biopsy of the lid was done, which showed poorly differentiated meibomian gland carcinoma with vegetoid spread and ocular surface squamous epithelial infiltration. The patient underwent partial thickness lid sparing excenteration. So persistent signs not responding to medication should prompt biopsy. It will facilitate management of easily treatable lesions and early surgical excisions. Overpouring of steroids can be avoided in OCP, and early immunosuppressants can be initiated in lichen planus, which can prevent further stages of cicatrization. Thank you.
Nice compilation. Like lichen planus case, how did you come to a diagnosis?
Only with biopsy, sir. Otherwise, it is clinically the same as OCP only.
What are you had any systemic this particular patient? Any systemic
No,
association?
sir, all lichen planus patients didn't have any systemic symptoms or associations.
Only eye.
Only eye. No, sir. But the oral immunosuppressants was started by rheumatologists, sir. So they had a systemic evaluation. They didn't.
They accepted the ophthalmologist diagnosis. And normally they don't accept.
Yes, sir, because it was a biopsy proven lichen planus.
Next we have Dr. Hasna K, who's presenting on long-term refractive and visual outcomes after topography guided photorefractive keratectomy.
Good afternoon. My topic is long-term refractive and visual outcome after topography guided photorefractive
Timer.
keratectomy (PRK). Laser vision correction is now established as safe and effective treatment for refractive error. It is associated with excellent visual outcome, improved quality of life, and high patient satisfaction. Rapid advances in technology and innovation have increased the range of refractive surgical options available to patients. Surface ablation uses an excimer laser to expose and remove the corneal stroma after removing the corneal epithelium. It has improved safety, especially in patients with high myopia and thin corneas. Topography guided laser ablation attempts to create more uniform corneal surface to reduce aberrations and while also correcting the spherocylindrical refractive error. The basic idea in topo-guided PRK is to target the excimer laser spots to flatten the steeper portions and to steepen the flatter areas by ablating around the flatter areas. Centration is based on the corneal apex and not on the pupil center, and thus it negates the angle kappa issue. We have studied the outcome of topography guided surface ablation in virgin eyes. The aim of the study was to evaluate the long-term refractive and visual outcome after topo-guided PRK. The study was a retrospective chart review. Data of all patients who underwent topo-guided PRK from January 2018 to December 2019 was collected. The data of their follow-up at 3-month and 2-year procedure were also collected. Inclusion criteria were age more than 18 years with stable refraction, central corneal thickness more than 460 microns with preoperative refractive error between -0.5 to -7, spherical myopia between 0 to 3 cylinders of astigmatism. Exclusion criteria included PACI less than 460, eyes with a significant dry eye, cataract, corneal scarring, keratoconus and other corneal ectasias, chronic inflammatory diseases, retinal and optic nerve diseases, and systemic conditions including autoimmune diseases, pregnancy and lactation. Patients who met the above criteria who underwent topo-guided PRK and having follow-up of 2 years following the procedure were recruited for the study. The laser ablation platform used was an MEL80 laser system by Zeiss with CRS master treatment planning software. The patients selected for topo-guided PRK were those with PACI less than 500 with high refractive errors and low flat K values, which cannot be taken for standard procedure. The outcome measures of interest are uncorrected and best corrected visual acuity, manifest spherical equivalent refraction, sphere and cylindrical cylinder, each parameter measured pre-op, third post-procedure, 3rd month post-procedure, and 2-year post-procedure. Statistical analysis was done using Stata version 11. Mean and standard deviation were calculated for all data. Pre and post PRK values are compared using the using paired t-test. The data of 77 patients were collected. Mean age was 26.18 plus or minus 4.86. Paired t-test was used for analysis. The preoperative uncorrected visual acuity improved from in the logMAR unit improved from 1.11 to 0.12 at 3 months, and it was at the end of 2 years it was 0.34. Best corrected visual acuity improved from 0.13 plus or minus 0.15 to 0.09 at 3 months and 0.08 at 2 years. This is the spherical equivalent improved from minus 5.05 to minus 0.06 at 3 months, and it was at minus 0.05 at the end of 2 years. This is the comparison of preoperative and 2-year postoperative spherical equivalent in those patients. You can see this arm shows 70 out of 77 patients had 0 spherical equivalent. And this is a graph showing the preoperative best corrected visual acuity compared to postoperative uncorrected visual acuity in topo patients. And you can see in this 6-6 arm, you can see more patients are falling in this postoperative arm compared to the preoperative arm. Yes, there is a dip here that is due to the undercorrected patients. We had to undercorrect some of the patients, and that is causing this dip. Otherwise, all patients are getting even better than preoperative best corrected visual acuity. At the 2-year follow-up, more than or equal to 0.18 logmar visual acuity was observed in 77.92% patients. The percentage of eyes having spherical equivalent within plus or minus 1 diopter achieved at 2 year was almost 97%, that is 75 eyes. At the 2-year follow-up, zero spherical equivalent was observed in 90% of patients. Topography guided treatment has improved outcome with kertorefractive procedures, correction of corneal higher order aberrations, high astigmatic errors, and anterior surface regularization for ectatic corneas. In a study conducted by Stulting et al., 249 eyes, it was found that the topo guided treatment showed good visual outcome with stability up to 1 year. Study by Hashmani et al. Demonstrated good efficacy, predictability, and stability of eyes undergoing topo-guided LASIK. It induced fewer higher order aberrations and less coma than wavefront optimized LASIK. Multiple studies have shown fewer higher order aberrations in topo-guided LASIK when compared to other modalities. With the advent of topography guided ablation, we can now offer patients not only freedom from glasses and contact lenses, but also likely improvement in best corrected visual acuity also. There were a few limitations in our study. Firstly, this was a single arm study and we were not able to make direct comparisons with other modalities like wavefront optimized or wavefront guided ablation. Secondly, we were unable to perform a subjective assessment of higher order aberrations as we don't have the facility at our center. Conclusion, topography guided PRK treatment produced excellent visual outcome in eyes with high refractive errors and thinner corneas. It is a good option for of laser refractive procedure for patients with high refractive errors and thinner corneas when there is no option for other advanced laser refractive procedures available. Thank you.
Nice, Pashalian. Thank you. Next, we have Dr. Sugarang Ranjini presenting on a rare case series of coexisting keratoconus and PMD in a single eye. Okay.
Sugaranjan. Good afternoon to one and all. At the outset, I would like to thank KSOS for giving me this opportunity. And today I'll be presenting on a rare case series of patients with coexisting keratoconus as well as pellucid marginal degeneration in the same eye. 10% of the patients with pellucid marginal degeneration are reported to be associated with keratoconus, but little is known about their characteristics. So we set out to do exactly that, to study the ophthalmic characteristics and treatment outcome for patients with coexisting PMD and keratoconus. So our diagnostic criteria was slit lamp examination showing the presence of two areas of thinning, that is a band-shaped peripheral corneal thinning, along with a central or paracentral stromal thinning and clinical features suggestive of PMD and KC. Scheimpflug imaging as well as anti-segment OCT confirmed the documentation of the two areas of thinning. Topographic features were studied, but they were not included in our diagnostic criteria. So it was a retrospective analysis and 7 eyes of 5 patients were enrolled. All the eyes had inferior band of thinning documented on slit lamp, Scheimpflug as well as anterior segment OCT. The mean age of the patient was 37 years. They were predominantly males and they had a unilateral presentations. And in cases with unilateral presentation had a association of keratoconus in their contralateral eye. And all patients had features of keratoconus in their central cornea. In the interest of time, I'll be discussing 3 cases only. This is a 33-year-old female who presented with warts in the central cornea with scarring and thinning, along with an inferior thinning. This was documented even on Scheimpflug images where central and inferior thinning was picked up. And this is also so beautifully shown in the anterior segment OCT. The topographic feature is not included in our diagnostic criteria, but as we can see in this particular eye, the topography does not fit into either of the diseases. And the contralateral eye showed features of keratoconus, and in Scheimpflug imaging, an inferior thinning was not noted. This patient underwent deep anterior lamellar keratoplasty with a large diameter graft and had a good visual outcome. This is a 44-year-old male who presented with a central corneal scarring and thinning, and also with an inferior thinning suggestive of a KC and a PMD in the same eye. The Scheimpflug image again shows the two areas of thinning in the same eye, also beautifully picked up on a anterior segment OCT. The topography again does not fit into either keratoconus or a pellucid, and the contralateral eye shows features of keratoconus. And this patient underwent a penetrating keratoplasty followed by cataract surgery many years later with an IOL implantation, and again a large diameter graft was used and he had a good visual outcome. This is a unique case where there was a bilateral presentation. In this, as we can see from in the left eye, there was a central as well as an inferior thinning picked up on Scheimpflug. And in the right eye was not such an advanced disease and the thinning was much more subtle. Since the left eye had an advanced inferior thinning, we went ahead and did a sclerocorneal intralamellar keratoplasty in this eye to strengthen the inferior cornea. And then we did the central corneal cross-linking for control of the keratoconus in the central part of the cornea. In the other eye, only corneal collagen cross-linking was done, but with a wide area of epithelium removal and a large diameter UV beam of 9 mm was used with limbus protection. Again, the topography features don't fit into anything in particular. And this patient did not have a significant visual outcome as compared to the penetrating keratoplasty and DALK patient, and she was advised to use contact lenses. So coming to the discussion, keratoconus with pellucid marginal degeneration has been reported as far back as in 1984, where 17 patients of PMD were noted to have KC in their central portion of the cornea. And this large retrospective study of PMD conducted in LV Prasad Institute in India agrees with our findings of a male association and a weak association of allergy present in these patients. In a national survey of pellucid marginal corneal degeneration done in Japan, when they studied the contralateral eyes topographic features, patients with PMD were seen to have features of keratoconus in their contralateral eye. So this agrees with what we have also found in our study, that is unilateral cases can be associated with keratoconus in the other eye. So as we all know, and as illustrated by Lee et al., the claw-shaped pattern is not, diagnostic of PMD. And if one is relying only on a topographic pattern to diagnose a case of PMD in this coexisting pathology, it can be easily missed. And as we stressed in our diagnostic criteria as well, it is a diagnosis is mainly clinical using slit lamp and probably a Scheimpflug or an ASOCT. So what we propagate is that always look at the inferior part of the cornea also. When you're transplanting these patients, use a large diameter graft so that you include the area of pellucid as well. And early cross-linking of the contralateral eye is prudent. The limitation of our study is that the corneal topography that we used gives us only a 9 mm pachymetry map. A 12 mm pachymetry map would have been ideal to study the changes of a pellucid, but this was not provided by our map. So in conclusion, pellucid marginal degeneration can coexist with keratoconus, and it is vital to include all areas of thinning while planning a corneal transplantation in such patients. This is mainly to educate the coexistence of this entity and to spread awareness about it. Thank you so much.
Thank you. Nice presentation. Thanks. Next, we have Dr. Pravina Shyam, who will be presenting on botulinum toxin in acquired comet and esotropia, a retrospective interventional study.
Good afternoon, everyone. I'm going to present my study on the role of botulinum toxin A in acute acquired concomitant esotropia. As you all know, acute esotropia is characterized by rapid and unexpected onset, often leaving individuals with double vision, discomfort, and profound visual disturbances. And its potential for serious visual impairment definitely demands a thorough understanding of its etiology and optimal treatment strategies. There are mainly three types of acute onset esotropia reported in literature: the Swan type, the Bruin-Franciscetti type, and the Belshowski type. But literature also supports a recent increase in the incidence of acute esotropia among children and young adults with the onset of COVID-19 pandemic. This could be probably due to the rapid and profound shift in their lifestyles across the globe, leading to an exponential growth in gadget use, prolonged screen time, and excessive near work. Even though we have a variety of treatment modalities available, surgery always remains a mainstay of treatment. But the eating prism phenomenon makes it difficult to titrate the accurate surgical values. In such a situation, the Botox has revolutionized the treatment of acute esotropia with satisfactory outcomes in a short time. So we decided to study the effect of botulinum toxin A in the treatment of acute onset esotropia among pediatric age group and young adults. It was a retrospective study between Jan 2020 and June 2023. We included all patients with sudden onset esotropia, binocular diplopia, with no evidence of incompetency or EOM limitation. All patients were aged less than 30 years and had an angle of deviation more than 16 prism diopters. Those with any organic eye disease, history of occlusion therapy, previous systemic and intracranial diseases were excluded from the study. MRI brain was done in all cases to rule out an intracranial pathology. Binocular visual function assessment was done on a routine OPD basis on the previous day of surgery, which included the squint evaluation, the sensory fusion and stereopsis assessment. After administration of anesthesia, Botox A injection was injected into the muscle belly of medial rectus 5 to 10 millimeters behind the insertion point with a 27 gauge needle, and the doses were titrated based on the angle of deviation. Treatment success is defined as either orthotropia or an angle of deviation within 10 prism diopters. Recurrence is defined as a new onset diplopia or esotropia after 6 months of Botox therapy. Coming to results, we studied 27 patients with a mean age of presentation around 12 plus or minus 7 years, and we had equal number of participants in the pediatric as well as the young adult group. Majority presented with complaints of squinting as noticed by parents, and the most common gadget used was a smartphone. And 78% of our study subjects were emmetropes, and none of them had an uncorrected refractive error. The mean duration between the onset of symptoms in Botox ranged between 2 weeks to 28 weeks. Comparing the pre and post-operative angle of deviation, we found a statistically significant drop in the angle of deviation throughout the follow-up visit with maximum effect at 1 month post-injection. And these are the pre-operative and post-operative pictures of a 4-year-old and 24-year-old who presented to us with esotropia post-Botox therapy having excellent ocular alignment. On comparing the different outcome measures, nearly 51.8% attained treatment success and also regained stereopsis at the final follow-up, and 66.7% attained good sensory fusion with complete alleviation of diplopia. 4 patients did not show any improvement. 3 developed recurrence, 2 after 1 year of Botox and 1 after 6 months. 11 patients eventually had to undergo extraocular muscle surgery to attain optimal ocular alignment. When we compare the effect of timing of Botox therapy on the outcome measures, we found that all who took the Botox within 3 months of onset of symptoms had excellent ocular alignment, BSV and stereopsis when compared to those who took more than after 3 months. But the stereopsis results were not statistically significant. Coming to discussion, etiology of acute onset esotropia always remains a subject of debate and is often associated with sustained near-point demand, which can contribute to an imbalance between the accommodation and vergence mechanisms. And this could have caused the dynamic activation of medial recti muscles in our patients, consequently manifesting as esotropia, since none of our patients had uncorrected refractive error. And the primary objective is to alleviate troublesome diplopia, and Botox therapy stands out as an effective solution in that, as it reinstates the divergence ability of the patient. With this chemodenervation approach, we achieved a success rate more than 50%, enhancing the quality of life for our patients much more rapidly and earlier than a surgical intervention. Coming to residual ETs, even though Botox therapy reduced the horizontal deviations significantly to less than 20 prism diopters, we had a few cases of residual ETs which could be effectively managed through a prism therapy and divergence exercises, eliminating the need for surgery in this subset. And only 3 patients exhibited residual esotropia, large angle, more than 40 PD, compared to a preoperative count of 17 patients, thereby obviating the need for excessive resection surgeries in these subsets. We had 3 patients with recurrence, and we believe that this could be linked to a residual implicit deviation and persistent excessive use of mobile phones, which shows the importance of adherence to post-treatment instructions, which can influence the success of Botox. And we also found that an administration within 3 months is effective, as prolonged misalignment can lead to muscle fibrosis, scarring, change in contractile properties of the muscle, and also reduce the neuroplasticity and hence affecting the neural rewiring and muscle adaptation. Comparison with other similar studies definitely show that Botox is a globally recognized treatment option, and we could achieve similar results with other treatment studies. To conclude, I would like to say that while the benefits of botulinum toxin therapy are apparent, the treatment should be assessed individually for each patient, and it is definitely a preferred choice for early postoperative visual rehabilitation, and Botox therapy can obviate the need for large angle horizontal muscle surgeries, especially when it is administered as early as possible. Thank you. These are my references.
Nice. So, did you have any complication in your series?
No, sir. Usually we expect ptosis, which is the most common complication with Botox, but none of our patients had any complication.
Thank you.
Thank you, sir.
Next, we have on stage Dr. Rennie Phillip, and she's presenting on is it all relative, biometry and relative lens position in glaucoma and its effect on disease severity.
Good afternoon. Thank you for this opportunity to present the results of our study, Is it all relative, biometry and relative lens position in glaucoma and its effect on disease severity. Several biometric factors are known to be associated with glaucoma. In open angle glaucoma, the axial length is longer, whereas in angle closure glaucomas, the axial lengths are generally shorter. Additionally, the anterior chamber depth is lesser, but the lens thickness is more, and the lens is a little more anteriorly positioned in angle closure glaucoma. So in Asia, angle closure disease is much more common than in the West. And incidentally, we also have rising numbers of myopia. And it has been found that in angle closure disease, myopia can range between 0.09 to up to 22%. So these eyes may be longer, but they have a relatively narrow anterior chamber despite the longer axial length. Few studies in literature report the relationship between biometry and severity of glaucoma. Considering all this lacunae, we conducted this study to assess the ocular biometry in normal, open angle glaucoma, and angle closure disease eyes, which includes angle closure suspects, angle closure, and angle closure glaucoma. And additionally, in primary glaucomas, the angle closure and open angle, we also wanted to look at glaucoma severity using VFI and mean deviation based on the relative lens position. We prospectively recruited subjects in the glaucoma department of a tertiary eye care center who had vision of at least 618 and were phakic. And we excluded those having other ocular diagnosis other than the normal patients, the open angle glaucomas, and the angle closure disease. Additionally, glaucoma suspects and anyone with diagnostic dilemma were also excluded. We then analyzed results from 942 eyes of 474 patients and took details from history comprehensive evaluation, visual fields, and refraction for this study. The biometric parameters that we assessed included the anterior chamber depth, the axial length, the lens thickness, the lens position, which was calculated as anterior chamber depth plus half of the lens thickness, and the lens position divided by the axial length was the relative lens position, which we use as a proxy for crowding of the anterior segment. We used the appropriate test, and a p-value of less than 0.05 was considered significant. On looking at the results of patient characteristic and refraction, all factors were significantly different among normal, angle closure disease, and open angle glaucoma eyes. And the median age was highest in the angle closure glaucoma group, and the open angle glaucoma had the most myopic eyes. And in biometry, the angle closure glaucoma group also had the highest lens thickness and the least relative lens position, that is, eyes that were most crowded. We looked at the refractive errors depending according to diagnosis, and though we had myopes and hypermetropes over all the groups, it was generally seen that myopes were more common in open angle glaucoma and the hyperopes were more common in the angle closure disease eyes. Interestingly though, in open angle glaucoma, about 31.4% were hyperopes, and in angle closure glaucoma, about 20.6% were myopes. So we assessed patient character and biometry in angle closure disease and found that angle closure glaucomas was significantly older than the primary angle closure suspect or angle closures. And these also had slightly lesser hyperopia compared to the other groups, and the axial length was also slightly longer in the angle closure glaucoma group, as was the anterior chamber depth. However, the relative lens position or the lens thickness was similar among these three groups. We then assessed the difference in disease severity using VFI and mean deviation on visual fields, and characterized these features depending on the relative lens position outliers, that is those less than the 25th percentile or the slightly more crowded angles versus those greater than 75th percentile or the slightly wider angles in the angle closure glaucoma group and open angle glaucoma group were separately assessed. These results shown in the table are summarized here in this slide, which shows that the greater than 75th percentile angle closure glaucoma patients had higher age, higher spherical equivalent and lesser axial length and higher anterior chamber depth and lens thickness that was significantly different from the less than 25th percentile group. But in both the open angle as well as angle closure glaucoma eyes, the visual field index or the mean deviation did not differ significantly among the outliers. We also did a multivariate analysis and found that once you control for age and gender, none of the biometric or the refractive parameters were found to be significant. So we prospectively assessed the biometric parameters of patients in normal, open angle glaucoma and angle closure disease categories. There was a significant gradation of axial length and anterior chamber depth, with angle closure glaucoma eyes having slightly larger values compared to angle closure or angle closure suspects. This suggests additional anatomic and dynamic factors that are responsible for angle closure disease severity. And though I say that angle closure glaucoma eyes had the longest median axial length, it was still much shorter than the value seen in normal eyes. Compared to the study by Lee et al., who noticed that severe glaucoma had longer eyes and milder moderate, in our study we were not able to find any differences in mean deviation or VFI depending on the relative lens position or axial length. And we noticed that angle closure glaucoma eyes was slightly longer than the angle closure or suspect eyes, which was similar to the results from the Chennai glaucoma study. And similar to Young et al., who looked for myopia less than or equal to 0.5 diopters and found that 27% was seen in angle closure glaucoma. We had slightly lesser values because of the slightly different criteria, and we had a value of 20.6% and 31.4% for open angle glaucomas. So one of the limitations of the study is that we did not have any follow-up data because it was a one-time cross-sectional study, but we did recruit our patients prospectively and look at the disease severity using biometry and glaucoma. To conclude, the relative lens position is a severity of glaucoma is not affected by the relative lens position, and a longer axial length and anterior chamber depth in angle closure glaucoma suggests that additional non-biometric factors may be responsible for severity in angle closure disease. These are my references. Thank you for this opportunity.
A nice study. You had some slightly varying results from already published reports, no? The axial length as compared to results which you compared with the existing literature, slightly varying results were there, no? Slightly.
The values were slightly different.
So
yes,
any logic you propose for that? Like
for the values, sir?
Slightly different in India, our population.
We took a different sample and the numbers were also different. So as a result of that, we had slightly different median values. We used IO Master 700. In this, the Chennai glaucoma study, they used the ultrasound A scan. So the machines were also a little different, but our data set was also different. Thank you, sir.
Next we have Dr. Marian Pauli presenting on outcomes of lacrimal gland biopsy, a clinical pathological study. Oh, sorry, I read it wrong. Sorry, Dr. Shebin Salim. I said, sorry.
A very good afternoon to all. Studies on outcomes of lacrimal gland biopsy, a clinical pathological study. Due to the diversity of lacrimal gland disorders, a tissue diagnosis is encouraged for definitive diagnosis and appropriate management. So we studied demographics, clinical presentations, imaging features, and histopathology of biopsied lacrimal gland lesions. This was a retrospective observational study of a total of 37 patients. Only incisional biopsies were included. Excisional biopsies, non-viral etiology, and epithelial neoplasms were excluded from the study. This was carried out in a tertiary care center over the past 10 years. The mean age at presentation was 43.70 years, which was ranging between 15 to 76 years. All were females except 3 males. The mean duration of symptoms was 10.93 months. A lid swelling was the most common symptom noticed in 33 patients, followed by pain, redness, blurred vision, dry eyes, dry mouth, watering, ocular irritation, and hearing loss. So, a total of 34 patients presented with lid edema, of which 12 patients had mechanical ptosis. An enlarged palpebral lobe of the lacrimal gland was seen in 30 patients. Supratemporal conjunctival congestion, which was characteristic of lacrimal gland inflammation, was seen in 6 patients. A palpable mass in the supratemporal orbit was seen in 4 patients. Other signs noticed were parotid gland enlargement, tenderness, proptosis, preauricular lymph node enlargement. The blood investigation showed a normal level of serum inflammatory markers, including ESR and CRP, in 23.33% cases of lacrimal gland inflammation. ESR was raised in 40% cases of inflammation and 42.86% of lymphoproliferative lesions. The CRP was raised only in 8 cases of lacrimal gland inflammation. So this shows that a normal level of serum inflammatory marker does not exclude any inflammatory pathology, and also in even in neoplastic etiologies, the inflammatory markers could be raised. The raised serum angiotensin converting enzyme was seen in 2 patients with the granulomatous inflammation, 2 cases of Sjogren's disease, and 1 patient with the IgG4 related orbital inflammation. Both cases of granulomatosis with polyangiitis, that is GPA, showed positivity for P-ANCA. Imaging was done in all patients, CT in 26 patients, MRI in 11 patients. The shape of the lacrimal gland was maintained in 31 patients. This was a case of sarcoidosis. Here we can see that both lacrimal glands are enlarged, but the shape is maintained. And it was lost in 6 cases. The characteristic molding around the globe, which was a feature of lymphoma, was seen in only 2 cases of the lymphoproliferative lesions. So this was a patient with lymphoma. Here we can see that the mass is characteristically molding around the globe. This was again another patient with a lymphoma, but here that feature was not there, only the lacrimal gland was slightly bulky. Intracorneal extension was seen in 1 patient, globe indentation was seen in 2 patients, and scleral thickening in 1. So this was the histopathology diagnosis and the management. A total of 16 patients were found to have non-specific inflammation, and 14 patients had specific inflammation, which included 4 patients with granulomatous inflammation, 3 with IgG4 related cases, 2 with GPA, and 3 with Sjogren's disease, 1 parasitic granuloma, and 1 xanthogranulomatous inflammation. Lymphoproliferative lesions were seen in total of 7 patients, including 5 cases of lymphoma, 1 case of reactive lymphoid hyperplasia, and 1 Castleman disease. Patients were treated with different modalities, including oral steroids, immunosuppressants, disease-modifying anti-rheumatoid drugs, and biologicals, and also chemotherapy and external beam radiotherapy in case of lymphoproliferative lesions. We did a subgroup analysis between the non-specific and specific inflammatory group in terms of age, duration of symptoms, and clinical features and gender. There was no difference in any of these features. So these were all different patients with a different diagnosis, including sarcoma, IgG4 related inflammation, lymphomas. But here we can see that all of them presented with a clinical feature of lid swelling, and the lacrimal gland is enlarged and congested.
But when it come to laterality, we can see that out of the 16 patients with non-specific inflammation, 11 were unilateral, and out of the 14 patients with specific inflammation, 11 were bilateral. So this was statistically significant, suggesting that when the patients present with a bilateral disease, that is more suggestive of a specific etiology. Associated systemic involvement was seen in total of 7 patients. This was seen in cases of GPA, sarcoidosis, granulomatous inflammation, and in one was a non-case of non-Hodgkin's lymphoma, and also in case of xanthogranulomatous inflammation. The median follow-up duration was 6 months. 10 patients were lost to follow-up. Complete resolution was seen in 22, and 5 patients were still under treatment at the last follow-up visit. So this was a lady with a 23-year-old lady who presented with bilateral redness and swelling of the eyelids. On examination, she had both eyes, this enlarged and slightly congested lacrimal gland. The imaging showed an enlarged lacrimal gland which with a contiguous inflammation extending posteriorly. So in this, we did a blood investigation which showed a raised RA factor and ESR, but CRP and AC was negative. So the biopsy was done, which showed features suggestive of IgG4 related orbital inflammation, including reactive lymphoid follicle in the lacrimal gland. There was concentric fibrosis around the lacrimal ducts. There was phlebitis, there was fibrosclerosis. And immunohistochemistry was done, which showed IgG4 plus positive cells suggestive of IgG4 related orbital inflammation. The literature suggests lacrimal gland insertion biopsy in patients who do not respond rapidly to antibiotic therapy, but how rapidly it is not defined. Though a course of oral steroids is preferred prior to biopsy, it can lead to misleading phenomenon of clinical improvement because of apoptosis in lymphocytic lesions. So it will be ideal to consider orbital biopsy first in orbital inflammation, especially in lacrimal gland inflammation. So we have different approaches for taking a biopsy. We can either go by an anterolateral orbitotomy or a transeptal approach. So what is important is differentiating it from the fat, that the preaponeurotic fat, that is totally yellowish in color. The lacrimal gland will be slightly firmer in consistency and more pale pink in color. A biopsy sample should be minimum of 2 into 2 into 2 millimeter, and it is always important to take a deep biopsy also. So we compared with the previous few studies. Here it shows that around 38 to 43% had non-specific inflammation in all the studies, but altogether the specific and lymphoproliferative etiologies could be seen in more than 50% of cases in all the studies. To conclude, a low threshold for lacrimal gland biopsy is advocated, especially in case of bilateral involvement. Thank you.
Nice collection of cases. Thanks. Next we have she finished. Nandan. Okay. Vigil, absent. Okay. Dr. Kiran Chandran, presenting on patterns of confocal blue reflectance in type 2 macular telangiectasia.
Hello. Yeah. So good afternoon, everyone. I would like to thank KSOS for giving me the opportunity to present in this conference. The topic is patterns of confocal blue reflectance in type 2 macular telangiectasia, also called as MACTEL. So the MACTEL in the initial stages is characterized by a loss of retinal transparency, predominantly visible temporal to the fovea, and this is classified as per the Glasson Blody staging into stage 2 MACTEL. So studies have been done demonstrating this phenomenon using short wavelength light, also called as confocal blue reflectance, in the wavelength spectrum of 488 nanometers. And the main idea of using this technology is that the macular pigment loss, which is central to the pathophysiology of MACTEL, is picked up well on confocal blue reflectance. And the typical pattern that we see is well-defined area of parafoveal hyperreflectance in the macular area, and it helps in early diagnosis of the disease. So here's an example which shows a clinical example which shows not much parafoveal graying in the macula, but confocal blue reflectance over here shows a well-defined area of parafoveal hyperreflectance. Fundus autofluorescence only shows a faint hyperautofluorescence at the fovea, and fundus fluorescent angiography shows late phase hyperfluorescent leak from the telangiectasias, and the overall area of macular involvement is great in CBR compared to fundus fluorescent angiography. So CBR is an excellent modality in MACTEL, especially in early cases. So here's an example which shows CBR picking up early changes of macula in the form of parafoveal hyperreflectance in the temporal macula even before clinical photo and fundus fluorescence picked up the changes. On spectral domain OCT, we can see a faint hyperreflected dots just overlying the external limiting membrane, whereas no other structural abnormalities are appreciated. So ours was a single center observational study which recruited patients based on a confirmation of macula clinically on gas and body staging and further confirmed on multimodal imaging. And Blu-ray reflection images was confirmed by using a Heidelberg spectralis system using a red-free setting in a specific wavelength of 488 nanometers. We excluded eyes with any other macular pathology and with poor imaging qualities, presence of artifacts, and we also excluded images in which CBR was not done as an initial test because there is a phenomenon called as bleaching of photopigments, and thereby we give a patient adequate amount of dark adaptation time, approximately around 10 to 15 minutes before proceeding with CBR. So the following were the CBR patterns or grading which we analyzed in our study, and I demonstrated this in our figures over here. We place an ETDRS grid over here centered on the fovea, and we place an imaginary line crossing vertically on foveal center. Any hyperreflectance which falls temporal to this imaginary line is taken as temporal pattern. And in the second pattern, the incomplete pattern, we see the hyperreflectance extending to nasal sectors. In third pattern, we have the complete ring pattern in which the outer and the inner borders of the reflectance are appearing uniform. In the fourth pattern is a broad pattern in which the predominant changes are dragged towards the foveal center. It could have a mixed pattern of reflectance, either hyper mixed with hypo. And the fifth pattern, irregular pattern, in which none of the above reflectance patterns are followed. That's an irregular pattern of reflectance. So analysis was done using Kruskal-Wallis and Fisher's exact test, and 302 eyes of 160 patients were analyzed. Majority were females, and average age of 60 years, and mean follow-up duration of 32 months. So the CBR patterns at presentation and subsequent follow-ups, the majority of the patients had complete ring with inner circumferential hyperreflectance, followed by broad pattern, and only very few eyes had incomplete pattern, temporal and irregular pattern. So the mean best corrected visual acuity actually showed a stepwise decrease as we progressed from the temporal to the irregular pattern, and it was statistically significant. The CBR patterns are compared to the stage of macula. The early stage of macula, that is stage 2 and 3, had majority of eyes in the temporal incomplete pattern, and the complete ring with inner circumferential hyperreflectance had got more even distribution between stage 2, 3 and 4 mactal eyes. The broad pattern were mainly seen in eyes of stage 4 and 5 mactal, and all eyes with the irregular pattern had got stage 5 mactal, that is proliferative stage of mactal, at presentation and at follow-ups. So the CBR pattern was also compared to macular area. Now macular area is defined as the overall extent of maximum hyperreflectance seen on CBR, and as we see, the temporal pattern had lesser area of macular presentation at presentation follow-up, and followed by the irregular pattern had the maximum area of macular presentation. So here's a case 1 example which shows that hyperreflectance is predominantly focused temporal to the macula, as demonstrated by a green arrow. At 12-month follow-up, the patient has presented with faint hyperreflectance involving the nasal sectors, and after 2 years of follow-up, this superior sector has also been filled up to form an incomplete pattern of reflectance. This is another example which has a 4-year follow-up. At the initial follow-up, the patient has got a predominant temporal hyperreflectance pattern, and after 4 years of follow-up, the patient presented with hyperreflectance even extending nasal to that imaginary line, so forming incomplete reflectance pattern. The OCT changes shows mild progression with mild collapse and progression of the ellipsoid zone loss extending even parafoveally. In this example, we can see that the complete ring pattern with the inner borders well differentiated, but on follow-up we can see that the nasal sectors, it's showing broadening of reflectance focused towards the foveal center. The inner borders, which are seen delineated by the red arrows, are not clearly differentiated in the follow-up pattern. The best corrected visual acuity is dropped and the macular area has progressed too. And these changes can be well delineated on spectral domain OCT as well, with progression of the neurodegeneration and ellipsoid zone loss. In this example, we can see that the structural changes are mainly focused on the region enclosed within the inner border of the CBR, whereas the regions external to it, external to the inner border, do not show much of structural changes in OCT. So increased CBR within the parafoveal areas is in all cases, except in different patterns and intensities, and this is mainly related to the lack of macular pigments in mactal. So the abnormal distribution of macular pigment was related to the impaired trafficking and storage of 3 pigments, basically lutein, zeaxanthin, and mesozeaxanthin. So dual wavelength autofluorescence similar to CBR also shows similar pattern of macular pigment distribution, starting initially temporal to the foveal edge, progressing centripetally involving the foveal center, and finally encompassing an oval area centered on the fovea. So the later stages of macular are characterized neurodegeneration considered towards the foveal center. Concluding, CBR patterns are related to the macular stage, BCV, and macular area, with temporal pattern associated early stage macule and broad annulus and irregular patterns associated in late stage macule and with greater area of involvement. So relevance of the study, CBR is mainly seen in early stage of macule, which is very relevant to the clinical diagnosis, thereby helping in counseling the patients about a disease. Thank you. Yeah, spectral domain, the Heidelberg spectralis system. So.
After bleaching, you did not get the same pattern as
we don't get the same pattern. You need to get sufficient amount of dark adaptation, around 10 to 15 minutes for that that exact pattern to again be replicated actually. So it's usually picked up in Heidelberg because it's a confocal scanning laser ophthalmoscope. Any system which uses a confocal scanning laser ophthalmoscope picks up this phenomenon beautifully. Because the blue reflectance also has a small element of autofluorescence. So that's why they say that the bleaching phenomenon is affecting the pigments actually.
You didn't try to correlate with the functional outcomes, like only structurally or correlated?
Yeah, structural, functional, only the visual acuity basically.
You didn't try to correlate in this particular study?
So which one, sir?
The functional outcome with the patterns.
Yeah, only the best criteria visual acuity was analyzed as per functional outcomes actually. Yeah.
Thank you.
Thank you, sir.
Our speaker today will be Dr. Nandana Bashir.